Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome everyone again to our second episode of Meet the Master podcast with our dear Professor Dr. Abdul Fattah Al-Asfar. Welcome, Dr. Abdul Fattah. We are always happy to have you with us.
Thank you, Osama. I am always happy also to be with you.
Thank you very much for your time. And today we are discussing another important topic of heart failure. And today we will talk about the four pillars, or the Fantastic Four, or the quadruple therapy of the heart failure. And our main theme is which early and which late. So, Dr. Fattah, let's start with a general question about the four pillar therapy for heart failure. What's unique about this four pillars or four groups of drugs in patient with heart failure?
Yeah, thank you, Osama, for the question. What is important about the four pillars is that we have strong evidence that these four pillars increase the favorable outcome in heart failure patients. They reduce the mortality, they reduce the heart failure hospitalization by very good evidence. So, and these are the maximum four medication that achieved the best evidence to improve the outcome in heart failure patients, especially heart failure with reduced ejection fraction. Those are patients with heart failure and the ejection fraction is below 40%. So, giving those four pillars to heart failure patients, you achieve the best available outcome, the best available evidenced outcome for those patients. So this is important. This does not mean that these are the only medication we are using in heart failure, but this means these are the top four medications that are essential for heart failure patients to be used to improve the outcome of this bad syndrome.
Actually, Dr. Fattah, this is my second question. Are these four pillars sufficient alone in a patient with heart failure?
No, of course, they are not sufficient alone. We need other medications, but when we see four pillars, mean the drugs that we have evidence, clear clinical trials, well-designed clinical trials that prove benefits. We have many other medications which we use for heart failure, but with less evidence. Either with less evidence because the trials was not that significant like this medication, or because we didn't have a clinical trial because of ethics. For example, Lasix or furosemide. Furosemide, sometimes we will call it the fifth pillar. It's very essential for patients who are having volume overload. We cannot neglect the importance of Lasix, but we don't have well-designed trial that show Lasix versus no Lasix. So that's why we didn't include it in the as a fifth pillar. Also, there are other medications also which are second-line therapies. For example, we have hydrolysis and nitrate combination. This medicine is very important in patients who cannot tolerate the renal angiotensin system blockers for many reasons, like renal failure, like hyperkalemia, or even in black population, there is evidence that this medication work well, hydrolysis and nitrate combination. Also, the digoxin, for example, this medicine also can be used to improve the quality of life of certain patients, and even in patients with atrial fibrillation can be used to reduce the heart rate. And also there are some new medications also with some evidence that has been introduced recently in practice, like, for example, guanylate cyclase stimulator, like vericiguat, also has some uses in heart failure patient. Another medicine is under certification by the health authorities, omecamtiv mecarbil. This is a heart rate reducing agent, can have some evidence also in heart failure. Many other medications also, like anticoagulation for DVT prophylaxis, any medications for the etiology like ischemic heart disease, coronary artery disease, also device therapy, advanced therapies. So there are a lot of big, huge platform for the treatment of heart failure. But when we say 4 pillar, we mean the most evidence-based medications. Sometimes we call them disease-modifying agent. Sometimes we call them guideline-directed medical therapies because they have very good evidence, very good designed clinical trials, and clear evidence in terms of hard endpoints, especially cardiovascular death and heart failure hospitalization reduction.
Okay, Dr. Fatah, but let me ask about certain drugs that is widely available and widely used in heart failure patients, like, for example, ivabradine. What do you think in such a drug in patient with heart failure and somewhat slightly high heart rate? Do you think it's maybe beneficial for a patient with chronic heart failure?
It's a very, thank you very much, Uthama, that you remind me by ivabradine. This is also a very important medicine outside the idea of 4 pillar. This medicine also is a heart rate reducing agent. It works only on the SA node. It reduces heart rate by blocking the FH channel in the SA node. Heart rate has been emerged for a time as a target in heart failure therapy. So there is one study, the SHIFT heart failure study, which has been published in 2010 and showed benefit of ivabradine in patients with persistent increase in the heart rate after achieving the target dose of beta blocker, or in patients who are not tolerant to beta blocker and their heart rate remain higher than 70.
Okay.
So in those kind of patients, if we added ivabradine either on top of beta blocker or in those who are not tolerating beta blocker, there is good evidence that this medicine also improves the outcome of especially heart failure hospitalization. The mortality was very modest. The mortality benefit was very modest in the SHIFT study. So the main benefit was in reduction of heart failure hospitalization. And also there is good evidence about improving the reverse remodeling, especially in patients with non-ischemic cardiomyopathy. So this medicine has a role in heart failure therapy, especially in patients who are not tolerating beta blocker. And if on top of beta blocker, if the heart rate, we fail to achieve heart rate lower than 70 beat per minute. This is the sector of indication of ivabradine.
So it's a second after the beta blocker. That's one
It
of
should
the
be after the
major.
beta blocker.
Okay.
It should
Okay.
never be before the beta blocker. This is after the beta blocker, or as a first line if the patient is not tolerating the beta blocker for any other reason.
Other drugs like the trimetazidine or the nitrates alone, there's some physician are still prescribing such medication for patient with a pure heart failure without any ischemic origin.
There is no evidence about the benefit of these medications in heart failure, either nitrate alone. They only might improve the symptoms of dyspnea, but they don't have any evidence about long-term outcome. Also, the same for trimetazidine. There is no evidence for any long-term outcome in patients with heart failure. They might have a role in patients with stable coronary artery disease, but they don't have any role in heart failure therapy.
Okay, so returning to our main topic, the 4 pillars, how to start these 4 pillars? Which is the best strategy to start them in parallel, or with some sequence do you recommend for starting such medication, the 4 pillars?
We always been asked this question, and it's not a matter of what is better, either to go parallel or to go sequential. The most important part is to reach the maximum tolerated dose of the 4 medication as soon as possible. This is the main important point. We prefer to go by the parallel approach. So you go by the 4 pillars in small doses, and then you go titrate one by one to the maximum, and you see the patient frequently until you reach the maximum tolerated dose for all the medications. If the patient is, especially with some population like patient on the hypotensive side, patient with borderline kidneys, we might opt to go with sequential introduction of this medication. So you can introduce two medication at first, then you introduce the second medication after 1 or 2 weeks, and so on. This is one of the approaches. This is the most important, is try to reach the full introduction of the four medication, and to reach the maximum tolerated dose of the four medication as early as possible. Before we used to say 6 weeks to 3 months, the period of up titration. But now, with the new evidence and because of the early benefits that we see in the early widening of the curve with most of this medication, sometimes we see the widening of the curve starting after 2 weeks in many medication like ARNI and like SGLT2 inhibitor. So it's better to initiate early these medications and to titrate them also as early as possible as the patient is tolerating them. So now we can say you can finish the titration even in less than 6 weeks, even in 4 weeks. And there is one study published recently, I think the response heart failure study. Yeah, the response heart failure study show that early titration of this medication, even finishing the titration in 2 weeks after discharge from acute heart failure admission, is beneficial than late titration in 6 weeks or 3 months. So I'm not saying this can apply for every patient, because at the end you should individualize and you should respect the phenotyping of every patient, because at the end there are big sector of heart failure patient who will not tolerate many of these medications. Yani I will give you example. In the paradigm heart failure study, they recruited 10,000 patients, and at the end, they succeeded only to randomize 8,000 patients. So 2,000 patients out of 10 means about 20%. They were not able to tolerate either of the medications, either ACE inhibitors or ARNI. So at the end, we have big sector of those patients, maybe 20%, maybe 30%, who will not tolerate one of these medication, or even we might have sector of those patients who may not tolerate any of these medications, because at the end we have patients with advanced heart failure who are always on the hypotensive side, who usually having a kind of moderate or severe kidney dysfunction with associated hyperkalemia. So those kind of patients will not tolerate any of these medications, or might tolerate a small dose of some of these medications. And those are the patients who will be considered for advanced heart failure therapies like CRTD, like LVAD, left ventricular assisted devices, like heart transplant. So at the end, not every patient will, but the majority, I can say clearly, the majority of heart failure patients, HFrEF patients, will tolerate these medications to some extent, and good sector of them, maybe 20 to 30%, depending on the practice, your practice, depending on the level of the clinic you are running, will not tolerate these medications due to variable reasons.
Okay, but regarding the example you showed us, Dr. Fattah, in a patient with relative hypotension, how in which order would you start the four pillars? If there is a certain order to start the four pillars?
Yeah, if the patient is on the hypotensive side or borderline kidney function, I always like to prefer the sequential approach on those patients. So my practice now is to, this is not an evidence-based practice, but this is from the expert opinion. Many expert opinion have advised us about that, and we noted it in our practice. We can initiate beta blocker and SGLT2 inhibitor as a first step, and then you delay the initiation of RAS blockers or ARNI, run ARNI and MRA at a later step, 2 to 3 weeks, 4 weeks after that. This might be more tolerable than initiating RAS blockers together with beta blocker MRA in the same time. So this for patient with hypotension or some renal impairment who cannot tolerate introducing the four pillars at one time.
Okay, but there is no evidence regarding either the sequential or the parallel approach. We have no
No,
evidence either for the short or the long term.
there is no head-to-head comparison by these approaches other than the response study that's published recently, which showed the not the parallel versus the sequential, but the aggressive approach versus the classic approach, which might take up to 3 months. So the aggressive approach, which might take 2 weeks after discharge, showed benefit in comparison with the conservative approach, which will take 6 weeks to 3 months. So this is the only study published recently comparing aggressive versus conservative titration of this medication.
Okay, and so in our practice and in our clinics here in Egypt, do you think the ARBs or the ACE inhibitor plus the other 3 pillars can be sufficient if we are looking about the price of the ARNI and these issues here? Can ARBs or ACE inhibitor be sufficient, or the benefit of these drugs can be comparable with the ARNI if we are looking from the financial issues or the financial problem of the patients?
Look, the weight of evidence about ARNI versus ACE is clear. ARNI are better than ACE, no doubt about that. The paradigm heart failure study is a landmark study, clear study, clear results, have been confirmed in many real life observational studies. The evidence is even more than double. The benefit is more than double. The consensus and solved studies of the ACE inhibitors hardly showed 16 to 18% benefit in terms of hard endpoints reduction. Added to them in the paradigm another 20%. So we have total of about 38% relative risk reduction of cardiovascular death and heart failure hospitalization by using ARNI. So there is no doubt that ARNI are better than ACE inhibitor. I always say ACE inhibitor are the weakest one in this guideline of medical therapies in terms of reduction of endpoints. Even weaker than MRA, weaker than beta blocker, weaker than SGLT2 inhibitor. So it's out of discussion that ARNI is preferred over ACE inhibitor. But when it comes to even cost effective than ACE inhibitor because of the prevention of death of hospitalization and the prevention of mortality. But if the patient really cannot afford, then what we can do? You don't have other option. So you can give the cheap medications, ACE inhibitors plus other pillars. But at the same time, you need to activate if you have authorities that can help patient to secure this medication, like insurance, like charities, like co-payment, like pharmaceutical companies, patient affordability plans by different way, even samples. We should do our effort to secure this medication for the patient. But if everything is blocked, we cannot do this, then use ACE inhibitor. Use ACE inhibitor plus the other 3 pillars after exhausting all other ways to secure the medication for the patient.
Okay. One of the most common problems that faced a physician who was treating a patient with heart failure is the problem of hypotension that occur after starting the 4 pillars. If such a problem occurred with the patient was okay, a good blood pressure, and after starting the 4 pillars, he started to have a hypotension, and the patient is symptomatic, saying, I am drowsy, I feel fatigue due to the hypotension. In which order we should start to stop or decrease the doses of the 4 pillars?
This is an excellent question. First of all, don't look to the 4 pillars. Number one, look at other medications other than the 4 pillar. For example, I see many patients in my practice using nitrate without use. They are not symptomatic. You don't have angina, and so routinely used, especially in Egypt, nitrates in every cardiac prescription
Okay.
even without need. So number one, stop this medication, stop nitrates if not needed, stop calcium channel blocker. Amlodipine, very commonly prescribed in those patients. Stop it. Sometimes I saw even alpha blockers are being prescribed
Okay.
on those patients to stop them. So this is step number one. Step number two, look at the diuretics. If the patient does not need the big dose of Lasix or whatever, decrease it. And sometimes we hold it, we stop it. And the best helper to you as a clinical hint in this regard is the propane B, N2 propane B. If you are using the N2 propane B, it will help you to exactly grade the functional status of the patient. So if the BNB is normal or approaching normal, this means the patient is not volume overloaded. So why to give him heavy dose of Lasix and compromising the blood pressure? So this is number two. Number two, look at the diuretic dose. Cut it or stop it. If
Okay.
after all these still the patient is hypotensive, then you may start to cut the four pillars, but make sure that this patient is not approaching the advanced stage. Because if the patient is not tolerating evidence-based therapies, this is the first alarm that this patient is in the advanced stage, and he might need advanced therapies like CRT, like LVAD, like heart transplant. If you want to start by cutting some medications, they always keep beta blocker and the SGLT2 to the end. The last to
Okay.
be, as I always say, the first to think about and the last to
Yes.
remove. The first to think about in borderline patient.
Okay.
In tolerating a patient, you introduce the four
The
pillar
four
and you keep
pillars.
the four pillar.
Okay.
In the
Okay.
borderline cases, on the hypotensive or poor kidney, the early to start beta blocker SGLT2 inhibitor for the overwhelming benefit, and the least to the last to remove are these medications. So you
Okay.
can start by decreasing the MRA, cutting it to half, stopping it completely, then go to the Entresto, cut it to half, stop it completely if the patient is still very symptomatic, and then go for the beta blocker and SGLT2 inhibitor. Make sure that the hypotension is symptomatic or not symptomatic, because many of half-ref patients tolerate lower blood pressure. Many of
Okay.
half-ref patients tolerate blood pressure of 80s, 90s. You see the patient cardiomyopathy, ejection fraction 20-25%, blood pressure 80, 85, and he's enjoying good quality of life. So
Okay.
why you stop the evidence-based therapies? So we always say symptomatic hypotension. This
Okay.
is the opposite to half PIF patient. Half PIF patient don't tolerate this lower blood
The
pressure, and
hypertension. Mm.
I don't advise to go down by the blood pressure to this level in half PIF patient. But in half ref sometimes. So step number one, look for other medication that if no need. Step number two,
Okay.
look at the diuretic dose.
Diuresis.
Step number three, look at the symptoms. Step number four, and the last step, think about. Step number four, think about advanced stage. Stage
Okay.
number five, start to cut the evidence-based therapies. So the last step is to start to think about cutting the evidence-based therapies.
Okay. But some physician advise the patient to use the Entresto or the Arni in half pill. They divide the pill. The company they have no specific recommendation, or they do not advise this practice. Do you think it's something that we can do?
I will be honest with you. I spent most of my early practice against this kind of practice. In the first two,
Okay.
3 years of using Arni, I was going by the 50, the 100, and then the 200. But
Okay.
later in my practice, I found that using the 25 milligram BID dose and going by 25 by 25 sometimes looks reasonable for some patients. And many patients really this succeed with them. So now I can say we don't have evidence 100%. I know the manufacturer didn't recommend that, but in our practice, it might work with some patients. So if the
Okay.
patient, especially those patients, very vulnerable, patient to post admission in the hypotensive side, you can initiate them by 25 BID interest. No problem with that.
Okay. Is there any rule for the alpha stimulant drugs to increase the blood pressure before cutting the evidence-based drugs?
There are
Give the
few
patient, for example,
there are
midodrine.
for many years, we in the heart failure community were against this. But recently, there was some, exactly since 2020, 2021, and it might be a little bit earlier, there are few scattered studies that show that adding this medication like midodrine, especially midodrine, can help in many ways, especially patients with the advanced heart failure, patients who are end stage, no other option for them. In my practice, for example, patients who are need for dialysis, they are always hypotensive. You cannot do anything for them to raise their blood pressure. So I give them midodrine to help with their blood pressure in this aspect. So it's a very restricted group of patients and should be by expert. Not everyone prescribed midodrine for every heart failure hypotensive patient. I mean, patients who are really in need for a blood pressure in the range of 90 or 100 for many reasons, like especially dialysis, especially severe symptoms like severe orthostatic dizziness, that compromising their quality of life. Then you can use this medicine. But to be honest, I don't have any justification to use it if you are using medication like Entresto or RAS blockers, whatever ACE or ARB. So I myself don't use midodrine to optimize the use of ARNI. This is using the midodrine is a later step in my practice. This means the patient is not tolerating ARNI, and I want more blood pressure for other reasons, not to use ARNI.
Okay. So for the last question, I'm just want to give you, Professor Dr. Al-Fattah, a case that we face every day, and you give us your opinion about how to start the 4 pillars. We have a patient who is 50 years old, presented with anterior myocardial infarction. He unfortunately arrived to the hospital very late after almost 16 hours. He went for a primary PCI, but his echo after the procedure showed a dilated left ventricular dimensions and impaired left ventricular function almost around 30%. The patient in the CCU now, do you recommend starting all the 4 pillars during the CCU admission or during the hospital stay, or we should wait at least for the first or the second day during the admission of such patient?
This is a very important question. This kind of patient are very risky patient, are very vulnerable patient. The benefits, the evidence on using the 4 pillars is still very shaky and very early. For example, ARNI, no benefit of starting ARNI too early if compared with ACE inhibitor, as evidenced by study. So you can use ACE inhibitor in this stage. You don't need to start ARNI too early. It's equal. No benefit, no further benefit of using ARNI on those patients. If you want to use ACE, especially the drug that was tried was Ramipril, I think. For beta blocker, we use once the patient is euvolemic, once the patient is decongested, you can initiate beta blocker at a small dose, of course. MRA can be used as a pre-discharge decision. No problem with that. We have good evidence about the EFSAS heart failure study post MI, and also we have new good evidence about the use of SGLT2 inhibitor post MI. So if the patient is MI, I think, if the patient is a blood pressure and kidney function is tolerating these medications prior to discharge, we do that. We send the patient to home on the 4 medication, not the 4 pillar, because ARNI is not included. We use ARNI, to be honest. I am working in a very high tertiary care center, so we use ARNI in this medication without any problem at all, if the patient is tolerating. And for those patients, exactly, we adjusted the dose of 25 milligram BID as a starting dose. So usually those patients need more time for admission. Usually they need a kind of a week in the CCU and then week in the step down. And in the step down time, use it to up titrate these medications. It will be much better to up titrate them during the step down admission, much better than introducing them in the outpatient. Because in the outpatient, you give the medicine and the patient is going to go home. You don't know what's going with him. So if you extend his admission 1 week more in the step down, like in the ward or in the intermediate care unit, high dependency unit, you're going to be more successful to introduce this medication than introducing it while he's at home.
Okay. Okay, thank you very much, Dr. Fattah. This was a wonderful meeting, and I hope we will see you again. I really enjoyed your high expertise, and I hope also our listener and our watcher will also enjoy this night meeting. Thank you very much, and I thank you very much for your time. Thank you, Dr. Fattah.
You're welcome, Osama. Thank you very much, and sorry for the disturbance that happened early in the recording. And hopefully, inshallah, see you again soon, بإذن الله.